Hello, doctors. How are you doing? How are you doing? How are you doing? Please let me know if you can hear my voice. Let me know if you can hear me. Okay, kindly let me know if you can hear me. I think I need to work on change this thing here. Yeah. Hello, please. Kindly let me know if you can hear me. Okay. I just want to know because some people are reaching out to me telling me that they can't hear me. So, hello, doctors, please let me know if you can hear me. If you can hear me, just type yes, yes, yes. Good. Okay, good. So, please don't also forget to let your friends know. We are having a class right away, so they should join us right now. Okay, good. Make sure you also sending this to as many friends, in your WhatsApp groups and everywhere, so they can join us. Welcome. If you don't know me, I'm called Dr. Brony. I'm the lead tutor at MedCognito, and we are here to help as many doctors as possible. Someone says my voice is very low. Is that the point? Is that true? Someone says I can't hear you. Please, doctors, can you hear me? Can you hear me? I want to know, can you hear me? Please, doctors, can you hear me? And if you can hear me, say yes. And if yes, is it high enough? So is it clear now, doctors? Please, I want to know, is it clear? Awesome. Okay. Great. I like that. Doctors, please go to our YouTube channel and subscribe. By the way, this morning we just hit 2,000 subscribers. Wow, that is powerful. We are growing with you, and we are doing it with you. Thank you very much for the support and for the love you show towards us. Please, I want you to go to our YouTube channel right now. If you are watching on YouTube, go there and click on subscribe. I'm going to start the presentation right away. Okay, I'm going to start the presentation right away so we can get into it. But that is the news for you. We just hit 2,000 subscribers on YouTube, and that is awesome. So please, if you're on this call right now and you've not subscribed to the MedCognito YouTube channel, doctors, I don't know what you're waiting for. We have only God knows how many subscribers, how many videos. Let me just check. How many videos do we have there for you? Just so that you can, munch on and study. And we have 326 videos. 326 videos covering QA1, NACOSKI, TDM, IELTS, OET. Doctors, please take advantage of it. We are doing this for you. All right. So please go there. Go to the live section. If there's anything you want to learn, go there and take advantage of it. You are the reason why we are doing what we do. Okay. All right. So let's go. So we just hit 2,000 subscribers. So that makes me very excited. Very excited. So let's start today's class. Today we are dealing with approach to dysphagia, a very important MCQ1 objective as well. Okay. And I'm going to just move on to the next slide so that we all can benefit from it. So why are we supposed to master dysphagia? You realize that the Medical Council states that dysphagia is defined as difficulty swallowing. It should be regarded as a clear sign of potentially serious organic pathology. So you realize something that, look, when it comes to the MCQ1 exam, the topics which have been selected for you to review, either what is the one word we all remember has been used over and over again, and then after that we'll look at this other word which the Medical Council has also been couching, and as we are going through the various rationales, we are seeing it. What is that one word? What is that one word that we have met over and over again? What is that one word? Common. Beautiful. Thank you very much, Dr. Saha. Common. Now, you realize that one other word I want you to add to the list of words which the Medical Council has been using is that if the condition is not common, another reason why they want you to learn a particular topic is that the condition is a potentially serious condition. So it's either a common thing that everybody knows, or it's a potentially serious thing that as a doctor you cannot miss. Okay, so two words. It's either common or it's either a potentially serious medical condition that you cannot miss as a doctor. All right, so it says that dysphagia is defined as difficulty swallowing. It should be regarded as a clear signal of potentially serious organic pathology, which therefore warrants careful and complete evaluation. All right, okay, good. So today we are learning two things. Either the condition is common or the condition is potentially serious. That is what the QB1 is all about. So it is common, therefore you must be able to manage it, and that is why it should appear in your exam. Or it is potentially serious, and therefore you cannot miss it, because if you miss it, the patient is going to die. Right? Okay. So what are the causal conditions that you need to master? Please write these down. If you are learning and you've not mastered all these topics, no, you've not started the game. The first topic is peritonsillar abscess. The next topic is pharyngitis. The next topic is, esophageal tumors and the rest, right? So that is where esophageal cancer will come in. That is where you need to learn about, the complications of recurrent gastroesophageal reflux disease, which can cause metaplasia in the lower one third of the esophagus. Okay, and then we even have Zenke's diverticulum. Doctors, please, I need you to write all these down so that if you've not mastered all these topics, boom, no, doctors, then you've not started the game. Okay, and then we have central causes. So one thing I want you to know is that we have oropharyngeal and esophageal dysphagia, but today I'm not going to go into all those nuances. So what are the types of dysphagia we need to know about? We have oropharyngeal dysphagia and we have esophageal dysphagia. The oropharyngeal dysphagia, these are the conditions which fall under it. We have structural conditions like peritonsillar abscess, pharyngitis, tumors, Zenke's diverticulum. And we also have neuromuscular causes of oropharyngeal dysphagia. For example, if somebody develops a stroke, right, that is a central neuromuscular cause of oropharyngeal dysphagia. And if somebody has a cranial nerve abnormality like amyotrophic lateral sclerosis, that is also a neuromuscular cause of oropharyngeal dysphagia. And then systemic myopathies like dermatomyositis. All right. And then we also have even xerostomia as well. All right. So please, these are the causes of oropharyngeal dysphagia. As I said, today I'm not going to go into the differences between oropharyngeal dysphagia and esophageal dysphagia. That is in the MedCognito course. All right. We've made that available in the MedCognito course. But then if you go on to esophageal dysphagia, okay, you will see what we call mechanical obstruction, where there can be intrinsic or extrinsic causes. And we also have neuromuscular causes as well. So the intrinsic causes are like things which are happening there in the esophagus itself. For example, lower esophageal ring, lower esophageal web, okay, esophageal cancer as well as peptic stricture. Okay, and then even patients who develop foreign body aspiration. So that is why you need to make sure that you master foreign body aspiration, in children, right? As well as eosinophilic esophagitis. And then we have extrinsic causes like mediastinal masses and neuromuscular causes like diffuse esophageal spasm and progressive conditions like scleroderma and achalasia. So doctors, please take a step back and make sure that you've written down all these topics. You need to, for your QE1, you need to master esophageal cancer. You need to master peptic stricture. You need to master how does esophageal cancer compare to peptic stricture? How does lower esophageal ring compare to esophageal web? How does a patient who presents with foreign body aspiration or foreign body swallow, which is, logged in the esophagus, how will that patient present? Will the patient present with drooling? How will a patient with esophageal eosinophilic esophagitis also present? Doctors, unless we've dealt with all these, how will a patient with scleroderma present? How will a patient with achalasia present? What about diffuse esophageal spasm? So if your reading is not hitting on these big topics, you've not started again. Doctors, please, can I proceed? Can I proceed? If I can proceed, let me know. Can I proceed? Can I? Doctors, I need feedback. If I can proceed, just type yes, 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 and let's go. Can I proceed now? Okay, good. So what we're going to do is that usually, I told you that I don't like putting the topic we are going to do first, because if I do that, then most of the time, the first question, a lot of you will get it right. So there's the first question I have for you. You have a 17-year-old male who presents to the emergency department with a sore throat, fever, difficulty swallowing, and a hot potato voice. On physical exam, there is unilateral swelling of the peritonsillar region with medial deviation of the uvula. The emergency physician is uncertain about the diagnosis. Which of the following is the best next step to differentiate between the various conditions? A, lateral neck x-ray. B, contrast enhanced CT scan. C, ultrasonography. D, direct laryngoscopy. And E, rapid streptococcal antigen test. So you have a patient, fever, difficulty swallowing, hot potato voice. There's unilateral swelling and peritonsillar of the peritonsillar region, and there's medial deviation of the uvula. And the doctor wants to differentiate between the various conditions. What's the next best step? Doctors, what's the next best step? Because if you know exactly what this thing is describing, fever, difficulty swallowing, hot potato voice, sore throat, doctors, what do you think? What is the condition? Like, before you even go on, what is the condition that you need to master? Which condition are we dealing with? Which condition are we dealing with? Okay, so Dr. Saha says it's a retropharyngeal abscess. Okay, so if it's a retropharyngeal abscess, what is the next best step according to guidelines that you need to do? What's the next best step according to guidelines that you need to do? I see a lot of people writing B, contrast enhanced CT, A, lateral neck x-ray, D, direct laryngoscopy. So someone also says drainage. Okay, what does the guideline say? What does up to date say? What does the recent teaching say? The answer is ultrasonography. The answer is ultrasonography. That is C. And I'm going to take my time and explain everything to you so that you know why C is the correct answer. So it is not A, it is not B, it is not D, it is not E. The correct answer is C. So the diagnosis the patient is dealing with is a peritonsillar abscess. Okay. Now, whenever you are dealing with a peritonsillar abscess, you need to ask yourself, is this a peritonsillar abscess through and through, or is a peritonsillar cellulitis? There's a difference. And in the course of the class, I'm going to explain it. Now, peritonsillar cellulitis and peritonsillar abscess can present with similar symptoms. Now, if you want to differentiate between peritonsillar cellulitis and peritonsillar abscess, the best initial tests, I'm saying again, the best initial test is ultrasonography. Now, I saw that someone wrote needle aspiration. I think I'll go back and check that response. Okay, somebody said drainage. I think that is Dr. Kim Tai. Okay, he said drainage. You do needle aspiration or incision and drainage if ultrasound is not available. This is what the latest evidence shows. And I'm very happy that we are dealing with this particular topic today because it's very, very important. Then, when do you do CT? Because it looks like a lot of people were also talking about CT scan. CT scan is useful for deep neck infections, but it's not the first line test for peritonsillar infections. Doctors, please, are we all tracking together? And lateral neck x-ray and direct laryngoscopy are used for other airway concerns, not peritonsillar abscess. And for you to do the rapid streptococcal antigen test, It is to diagnose strep throat, not peritonsillar infections. Doctors, please, I want to make sure that this settles in very well, because this is an area that a lot of candidates make a lot of mistakes, right? Next best step. Yes, as a peritonsillar abscess, you need to drain it. And we'll talk about all those things in the course of the class. But what's the next best step? How do you differentiate between peritonsillar cellulitis and peritonsillar abscess? This is the trick. This is the trick. Okay? This is the trick. Okay. So, I have another question for you. So, you have a 25-year-old female who presents with fever, dysphagia, and a muffled voice. Examination reveals asymmetric peritonsillar swelling with uvular deviation. The physician was suspecting peritonsillar abscess and proceeds with needle aspiration. Pus is obtained, which of the following is best describes the patient's diagnosis. Is this a peritonsillar cellulitis? Is it a peritonsillar abscess? Is it a retropharyngeal abscess? Is it a parapharyngeal abscess? Or it's a Ludwig's angina? So is it A, B, C, D, or E? There are 3 abscesses there. There's Ludwig's angina there. There's peritonsillar cellulitis. I'm trying to communicate something to you. Doctors, before you sleep tonight, after today's class, especially for this particular question, I know that there's a part in the stem which gives it up, right? But in this particular stem, it's also teaching you one thing, that I need to learn the difference between peritonsillar cellulitis, peritonsillar abscess, retropharyngeal abscess, parapharyngeal abscess, and Ludwig's angina. These 5 diagnoses, I need to be able to, even when I'm sleeping and I'm waking up, I need to be able to differentiate between these 5 differentials: peritonsillar cellulitis, peritonsillar abscess, retropharyngeal abscess, parapharyngeal abscess, and Ludwig's angina. Okay. And what's the correct answer? The correct answer is peritonsillar abscess. Because of the fact that there was pus on needle aspiration, it confirms peritonsillar abscess. And peritonsillar cellulitis does not have any pus collection. Okay. Peritonsillar cellulitis does not have any pus collection. Now, what about retropharyngeal abscess and parapharyngeal abscess? These occur in the deeper neck spaces. So usually they are not that superficial for you to just see the uvular deviation and the rest. Okay. What about Ludwig's angina? So today I'm using this particular question so I'll be able to differentiate between a lot of things. Ludwig's angina usually occurs on the floor of the mouth, and it does not affect the tonsils. So remember this: peritonsillar abscess and peritonsillar cellulitis occur and affect the tonsils. Retropharyngeal abscess and parapharyngeal abscess, they occur in the deep neck spaces, and Ludwig's angina occurs at the base. Okay, so while peritonsillar abscess is happening on top, retropharyngeal abscess is happening in the deep muscles, Ludwig's angina is happening in the middle. I want somebody to get me, or to type something which the person is using to remember. Because somebody's asking, why not retropharyngeal? Most of the time, retropharyngeal abscess, you will not see the classic presentation of swelling around the tonsils and deviation of the uvula. Usually, you rather see some neck swelling. And Ludwig's angina, you rather see that the tongue is elevated. And peritonsillar abscess, you rather see that the uvula is deviated. So, doctors, it's about where the thing is happening. It's about where the thing is happening. Okay? So, always think about this. Retropharyngeal abscess and parapharyngeal abscess occurs in the deep muscles of the neck. Peritonsillar abscess occurs around the tonsils and it leads to uvular deviation. And Ludwig's angina causes the tongue to be lifted up. Hello, please. Are we all on the same page? If you're all on the same page, let me know. And then we move on to the next step. If we're all on the same page, let me know. And we move on to the next step. Are we all on the same page? Beautiful, beautiful, beautiful. This is very good. Okay? So please, if you are presented with a case history, Is this peritonsillar abscess? Is it peritonsillar cellulitis? Is it retropharyngeal abscess? Is it parapharyngeal abscess? Or is it Ludwig's angina? These 5 diagnoses, you must know how to nail them in your MCQ1 exam. Okay, next one. You have a 30-year-old male who presents with severe sore throat and difficulty swallowing. Examination reveals a swollen peritonsillar region without pus or needle aspiration. Which of the following is the most likely diagnosis? A, peritonsillar abscess. B, peritonsillar cellulitis. C, retropharyngeal abscess. D, parapharyngeal abscess. And E, epiglottitis. Now that we talked through it, you see the way all of you are writing B, 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 B. And that is correct. That is peritonsillar cellulitis. Peritonsillar cellulitis will present similarly to peritonsillar abscess. However, there will be no pus. Okay, no pus on aspiration indicates peritonsillar cellulitis, okay, which is inflammation without abscess formation. Peritonsillar abscess will show pus collection, and retropharyngeal and parapharyngeal abscess occur deep in the neck. Epiglottitis is a different ball game altogether, and usually that affects the epiglottis. So, doctors, I think we are all getting the point I'm trying to make with these initial set of questions. Next question. Next question. You have a 21-year-old male who presents with fever, unilateral throat pain, and difficulty opening his mouth. Examination reveals peritonsillar swelling. The emergency physician suspects a deep neck infection and considers a peritonsillar abscess. If ultrasonography is not available or is unavailable, because we learned that ultrasonography is the first step in terms of investigation, what is the next best step? So, in other words, ultrasonography could not be done. Maybe there's no one with the expertise. What is the next best step? A, empiric antibiotic treatment. B, lateral neck therapy. C, needle aspiration or incision and drainage. D, blood cultures. And E, rapid streptococcal antigen test. I see doctors going for C. See doctors going for C. Many people are going for C. Many people are going for C. Does somebody have a different answer? A lot of doctors are going for C. Many people are going for C. Yeah, a lot of doctors are going for C. And what's the correct answer? C. C is the correct answer. So today you are learning that you don't just stick a needle into someone's throat. If you are suspecting that the patient has peritonsillar abscess, you ask yourself, is there ultrasound? If ultrasound is unavailable, then needle aspiration or incision and drainage is required to confirm pus collection. Why is starting the patient on empiric antibiotics wrong? Antibiotics alone is insufficient if there is abscess present. If it was just peritonsillar cellulitis, then antibiotics is okay. However, because of the way the patient is presenting, you want to make sure, is there a peritonsillar abscess or not? And if there is a peritonsillar abscess and you are just giving antibiotics, man, that patient is not going to recover. Okay, if there's a peritonsillar abscess, you want to make sure that you drain that abscess. Okay, what about lateral and neck x-ray? It is for retropharyngeal abscess or epiglottitis, not peritonsillar abscess. So this is also another learning point, and I need you to write it down. First investigation in peritonsillar abscess is ultrasound. Next investigation, if ultrasound is not available, is needle aspiration. We do lateral neck x-ray for patients with retropharyngeal abscess or epiglottitis. Now, blood cultures is not routinely needed unless you suspect that this patient has signs and symptoms of systemic infection. And then rapid streptococcal antigen test is to diagnose strep throat, not to diagnose peritonsillar abscess. Doctors, are we all on the same page? So someone is asking this. Please, the patient cannot open his mouth. Let's see. So it says that difficulty opening his mouth, but that does not mean that the patient cannot do it at all. Like, he's able to do it, but he does it with difficulty. Okay, so Dokua, I hope I've answered that question. And then someone is also asking, I thought needle aspiration and drainage is to differentiate between peritonsillar abscess and peritonsillar cellulitis. Yes. So this one, you realize that number one, the first thing you should have done to help you differentiate between peritonsillar abscess and peritonsillar cellulitis is you should have done an ultrasound, but there's no ultrasound. So you should definitely find a way to find to know, is this a peritonsillar abscess or a peritonsillar cellulitis? That is why you're going to stick in the needle, right? Okay, good. We'll come to indications for CT scan for peritonsillar abscess, but let's continue. So, doctors, now I'm just showing you a picture. Okay, so you realize that it looks like the roof of the mouth, the uvula is coming down, and the uvula is a bit deviated, right? The uvula here is a bit deviated. So this is where the abscess is forming. Okay. Now, note the types of peritonsillar infections. So now that we've done all these questions, we come into this particular one. Peritonsillar infections occur in the space between the tonsil and the pharyngeal muscles. Remember that this is totally different from retropharyngeal abscess and parapharyngeal abscess and epiglottitis and Ludwig's angina. Okay? Now, there are two types of peritonsillar infections. We have peritonsillar cellulitis, which is called phlegmon, which is inflammation of the peritonsillar region without pus collection. And we also have peritonsillar abscess. This is a collection of pus in the same area. So peritonsillar abscess and peritonsillar cellulitis occur in the same area. And what area is that? Between the tonsils and the pharyngeal muscles. Okay, but then peritonsillar cellulitis has no pus. Peritonsillar abscess has a collection of pus. And because of the presence of the collection of pus, it makes it a more serious infection. Okay. So, whenever you see this friend of mine, the doctor with the light bulb by the head, it tells you this is a eureka moment. So, peritonsillar cellulitis means there is inflammation with no pus. Peritonsillar abscess means that there is inflammation with pus collection. Okay. So somebody's asking here. So the first test for retropharyngeal abscess is lateral neck X-ray. Yeah, you got to get a lateral neck X-ray, and there are unique features on epiglottitis. There's a unique feature on retropharyngeal abscess. There's a unique feature. Okay, good. So how are we going to remember the key difference between peritonsillar cellulitis and peritonsillar abscess? I brought up this acronym called CAP. I usually like a lot of acronyms. So CAP is CAP. So C is for cellulitis. That means can't find pus. A is for abscess. That means a big pus pocket is present. And P is that you are going to poke with a needle to confirm, not to tell the difference, to confirm. The initial test is an ultrasound. If there's no ultrasound, you want to poke in with a needle to confirm. Okay. Now, since both conditions look similar, that is peritonsillar abscess, peritonsillar cellulitis, we need imaging or a minor procedure to confirm the presence of pus. So ultrasound is the best non-invasive method. Okay. Ultrasound is the best non-invasive method. And needle aspiration or incision and drainage is used if ultrasound isn't available. To check for pus with a needle is diagnostic. So, what if you have a patient, sore throat, hot potato voice, blah, 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 what's your next best step in terms of imaging, in terms of investigation? Do your ultrasound. What if there's no ultrasound available? Then you can do your needle aspiration or incision and drainage. Okay. So other related deep neck infections you need to learn are retropharyngeal abscess, which happens behind the throat, and then parapharyngeal abscess, which happens next to the pharynx. Okay. And these require different approaches, and you want to rule them out. That is why you want to do other investigations like the lateral neck x-ray. But if you are talking about parapharyngeal retropharyngeal abscess alone, or parapharyngeal abscess alone, no, if you're talking about what medical condition am I even dealing with today? If you're dealing with peritonsillar abscess alone, then you want to do your ultrasound. Okay, good. So let's move on from there and move on to the pathogenesis of peritonsillar abscess. Pathogenesis of peritonsillar abscess. Today we are dealing with peritonsillar abscess alone. So I have this question for you. You have a 30-year-old smoker who presents with unilateral sore throat, muffled voice, and difficulty swallowing. He is diagnosed with peritonsillar abscess, which of the following risk factors has been associated with development of peritonsillar abscess? A. Gastroesophageal reflux disease. B. Smoking. C. Chronic sinusitis. D. Epiglottitis. E. A history of dental caries. What's the correct answer? So some are going for C, chronic sinusitis. Some are going for E, history of dental caries. Some are going for B, smoking. E. Some are going for B. Some are going for C. So what's the correct answer? Risk factors for peritonsillar abscess. What's the correct answer? The correct answer is B, smoking. Correct answer is B, smoking. I thought this was going to be a very simple, walk in the park class. But it looks like we need to really take our time to really explain a lot of concepts. Smoking is a recognized risk factor for peritonsillar abscess because of its impact on mucosal immunity and salivary gland function. Smoking is a recognized risk factor for peritonsillar abscess. What about GERD? Even though GERD can contribute to chronic throat irritation, it is not directly linked to peritonsillar abscess. GERD is related to chronic throat irritation, but not directly linked to peritonsillar abscess. What about chronic sinusitis? It is more commonly associated with deep paranasal sinus infections, not peritonsillar abscess. That is for chronic sinusitis. What about epiglottitis? Epiglottitis is a separate upper airway emergency, and it has nothing to do with it. It is unrelated to peritonsillar abscess formation. Okay. What about dental caries? Dental caries are associated with odontogenic infections, but not directly with peritonsillar abscess. So if you're looking at infections of the gum and all those things, then dental caries are there. So one of the key risk factors for peritonsillar abscess is smoking. Okay, doctors, please write this down. And I've not received any pictures from anybody about how they are watching the class today. Please do well to send me some pictures on my phone number. I'm going to put my phone number at the base of the class. +1 306 891 5649 +1 306 891 5649. Smoking is a key risk factor for peritonsillar abscess formation. Okay. Next question. I have a 27-year-old male who presents with rapidly worsening sore throat, trismus, and difficulty swallowing. He's diagnosed with peritonsillar abscess. What's the most common progression of peritonsillar infections? A. Direct formation of an abscess without any preceding infection. B. Tonsillitis to pharyngitis to cellulitis to abscess. C. pharyngitis to cellulitis to abscess. D, retropharyngeal cellulitis to peritonsillar abscess. And E, obstruction of the Stensen's duct leading to peritonsillar abscess. What's the correct answer? What's the correct answer? What's the most common progression of peritonsillar infections? Direct formation of an abscess without any preceding infection, tonsillitis to pharyngitis to cellulitis to abscess, pharyngitis to cellulitis to abscess, retropharyngeal cellulitis to peritonsillar abscess, or obstruction of the Stensen's duct leading to peritonsillar abscess. What's the correct answer? So some are going for E, D, some are going for C, some are going for B. What's the correct answer? What's the natural progression? The natural progression is C. You move from pharyngitis to cellulitis. Remember that cellulitis is without pus, and then it goes to abscess. Okay, so the typical progression of peritonsillar abscess is, please, this one you need to write it down. Doctors, I'll give you time to write it down. Okay, the typical progression of peritonsillar abscess is, number one, pharyngitis, which is infection of the throat. Then it moves to peritonsillar cellulitis, that is a phlegmon. Then it moves to peritonsillar abscess formation. Let me say it again. The patient develops pharyngitis, which is this inflammation of the infection of the throat. Then it goes on to peritonsillar cellulitis, that is a phlegmon. Then it goes to abscess formation, that is pus collection. Okay. So those who wrote A as the correct answer, that is wrong. Because even though peritonsillar abscess can form without prior infection, it is less common, and usually it is as a result of the Weber gland obstruction. You don't need to worry your head about this. You don't need to worry your head about Weber gland and all those things. No. The most important thing is that for a patient to develop peritonsillar abscess without a prior infection, there should have been an obstruction of one of the salivary, one of the glands. Okay. Now, what about B? Tonsillitis is a separate condition altogether, and peritonsillar abscess more commonly follows pharyngitis than tonsillitis. So think about peritonsillar abscess as pharyngitis to cellulitis to abscess. Okay. And then D, retropharyngeal cellulitis leads to retropharyngeal abscess, while peritonsillar cellulitis leads to peritonsillar abscess. And then E, Stensen's duct is associated with the parotid gland and it's unrelated to peritonsillar abscess. So please write this natural progression down. From pharyngitis, it goes to peritonsillar cellulitis, then it can go to abscess formation. Okay, so what are the key takeaways here? The first thing is that peritonsillar abscess is most commonly located in the superior pole of the tonsils. Okay. Number two, the infection will progress from pharyngitis to cellulitis to abscess formation. Number three, smoking is a risk factor for peritonsillar abscess. Number four, the carotid sheath is a critical structure at risk of spread. Don't worry so much about that. Then number five, peritonsillar abscess can occur without prior infection due to obstruction of the Weber glands. However, the Weber glands are a group of salivary glands in the soft palate, and they are just superior to the tonsils. Okay, but the main thing you need to realize is that for peritonsillar abscess to occur without prior infection, that is without pharyngitis, moving to peritonsillar cellulitis, and then peritonsillar abscess, that is a bit rare. So always think about it for the board exam. Common things are common. Note point 2 very well. From pharyngitis to cellulitis to abscess formation. That is it. Okay. So I'm just showing you peritonsillar abscess again. The first one I showed you one on the other side. Now I'm showing you another one, on this other side as well, so that you can be able to tell. Okay, so that's how peritonsillar abscess is, and the uvula is moved to the side. Okay, so let's talk about the epidemiology of peritonsillar abscess. Let's talk about the epidemiology of peritonsillar abscess. Oh, somebody just sent me a message. Watching you from Vereeniging, South Africa. That's beautiful, doctor. So please, those pictures really help me a lot. So please send me more pictures. I love to see where you are watching me from. Okay. So somebody's asking, how is the patient going to breathe? So that is the more reason why peritonsillar abscess is a very, very important MCQ1 topic that you need to make sure that you've mastered, because it is in the objectives, right? Remember, in the objectives, it is either that the condition is common or the condition is life-threatening. These are the two things that you always have to keep in your mind. So don't just go learn some wild, highfalutin stuff. Always ask yourself, this thing I'm learning, is it common in Canadian practice, or is it life-threatening? So that is why, peritonsillar abscess is very, very important for you to master. Okay, so what's the epidemiology? I have a question here. Doctor, send me more pictures. Where are you watching me from? Are you watching me from Montreal? Are you sitting by your window and watching on YouTube? Are you watching with your family? Just share it with me. Are you watching with some friends? Are you in a study group and you guys are watching? Let me know. Just send me a picture. It gladdens my heart. So I have this question. Which of the following statements is most accurate regarding the epidemiology of peritonsillar abscess? So this is where public health and a medical condition meet together. A, peritonsillar abscess is the least common deep neck infection in children and adolescents. B, peritonsillar abscess is most frequently seen in elderly patients above 60 years of age. C, peritonsillar abscess occurs most frequently in adolescents and young adults, but can also affect younger children. D, the annual incidence of peritonsillar abscess is highest in children under 5 years of age. E, peritonsillar abscess has an annual incidence of 100 per 100,000 persons in the general population. I'm getting more pictures. So while you solve the question, I'm going to enjoy where people are joining us from. Dr. Kamwa says, I'm watching you from Moncton. Beautiful. Dr. Theo says, I'm watching you from Pretoria, South Africa. Wow. I'm glad that we are serving people across many divides. This is beautiful. Okay, so what's the correct answer? So some are going for B, some are going for C, some say C. Dr. Sipton says C, and the correct answer is C. Peritonsillar abscess occurs most frequently in adolescents, because I saw somebody who had chosen the fact that peritonsillar abscess occurs in very elderly people. No, peritonsillar abscess occurs most frequently in adolescents and young adults, but can also affect younger children. Okay, so it's the most common deep neck infection in children and adolescents, not the least common, because the question was saying peritonsillar abscess is the least common. That is wrong, right? It is rather the most common deep neck infection in children and adolescents, and it accounts for 50% of cases. Number 2, peritonsillar abscess is most common, not least common, deep neck infection in those people in those age groups. And option B is incorrect, because peritonsillar abscess is most common in adolescents and young adults, not in elderly individuals. Okay, and point D is also incorrect. Peritonsillar abscess is more common in adolescents. And then option E is also incorrect. So the main learning point here is that peritonsillar abscess is most frequently seen in adolescents and young adults, but can also affect younger children. Okay, awesome. Next question. You have a patient who presents with fever, dysphagia, and muffled voice. Examination reveals peritonsillar swelling. The physician suspects peritonsillar abscess based on epidemiological data, which we've just learned about. Which age group has the highest estimated incidence of peritonsillar abscess? So when you see PTA, I mean peritonsillar abscess. A, children less than 5 years. B, adolescents. C, adults 40 to 59 years. D, adults more than 60 years. And E, peritonsillar abscess occurs at equal rate in all age groups. What's the correct answer? More pictures coming in. Oh, Dr. Doreen is watching us live from Lusaka, Zambia. Live from Lusaka, Zambia. I'm also getting someone who is joining us live from Johannesburg. Wow. So this doctor has the laptop and also has a big TV screen. Wow. This is beautiful. Okay. So what's the correct answer? What's the correct answer? The correct answer is B, because we just learned about it. We just learned about it. Adolescents. Adolescents have the highest estimated incidence of peritonsillar abscess. That is 40 per 100,000. Okay. So now, while peritonsillar abscess can occur in young children, the incidence is lower than that of adolescents. So remember, peritonsillar abscess occurs more in adolescents than any other group of people. Okay, so what are the key epidemiological concerns about peritonsillar abscess? Peritonsillar abscess is the most common deep neck infection in children and adolescents. Okay, and peritonsillar abscess is most frequent in adolescents and young adults, but can also affect younger children. And the annual incidence of peritonsillar abscess is 30 per 100,000. You don't need to worry your head about all these numbers. The main thing are the two top points that I raised. You know, the ones I've highlighted: most common deep neck infection in children and young adults, and most frequent in adolescents and young adults. Okay. All right. So now that we've moved on, doctors, please, is the pace okay? Is the pace okay? Wow. Someone is joining us from Laval. Laval. Where is Laval, by the way? Which country is Laval? Which country is Laval? Where is Laval? I want to know. Where is Laval? Where is Laval? So the doctor who sent me, Dr. Mafu, can you let me know where Laval is? Where is Laval? Okay, let me know. Okay. Oh, it's in Montreal. Beautiful, beautiful, beautiful. Okay, so now let's go. So Laval is in Montreal. So doctors, if you want a steady partner, you have Dr. Mafu in Montreal, Laval. She will study with you. Okay. Okay, so let's go to this question on causative organisms. A 22-year-old male presents with sore throat, fever, and trismus. Examination reveals a unilateral peritonsillar swelling with uvular deviation. A peritonsillar abscess is diagnosed and drainage is performed. Microbiology assessment or analysis of the abscess fluid is most commonly likely to reveal which of the following predominant bacterial species: A, strep pneumo; B, strep pyogenes; C, Pseudomonas aeruginosa; D, Mycobacterium tuberculosis; and E, Candida albicans. So, in other words, this question is asking, when you do an aspiration of a peritonsillar abscess, okay, which organism are you likely to culture? A, strep pneumo; B, strep pyogenes; C, Pseudomonas aeruginosa; D, Mycobacterium tuberculosis; and E, Candida albicans. What's the correct answer? What's the correct answer? What's the correct answer? I see a lot of people going for B, and someone went for A. And looks like B, A, B, A. Okay, the correct answer is B. It's strep pyogenes, okay? Or group A, strep. So the correct answer is B. B. So peritonsillar abscess are polymicrobial infections, with group A, strep, being the most common bacterial species. Please write it down. Group A, strep, is the most common bacterial species. Okay, strep pneumo will cause pneumonia and otitis media, but is not a major cause of peritonsillar abscess. Question number C. Pseudomonas aeruginosa is common in nosocomial infections, but not a primary peritonsillar abscess pathogen. And then Mycobacterium tuberculosis, it causes tuberculosis and granulomatous infections, but not peritonsillar abscess. And Candida albicans, as we know, is a fungus and causes fungal infections, not a common cause of peritonsillar abscess. Okay, so I'm going to introduce you to the organisms which are usually seen in peritonsillar abscess. So we have Jennifer from Lagos as well, who is also studying with us. Jennifer from Lagos, beautiful, awesome. And then we have someone join us from Bentio, that is Rupkona. Wow, so many people join us from various parts of the world. That's great. So, which of the following best describes the microbiology of peritonsillar abscesses? A, they are typically caused by single bacterial species. B, they are primarily caused by fungi. C, they are polymicrobial and include aerobes and anaerobes. D, they are viral infections caused by Epstein-Barr virus. And E, they are sterile infections without bacterial involvement. What's the correct answer? What's the correct answer? What's the correct answer? While you are doing that, we're also getting a message from Nigeria, Dr. Chisom. Dr. Chisom from Nigeria. Beautiful. So, what's the correct answer here? The correct answer is C. So, the organisms which called peritonsillar abscess, they are polymicrobial, many different microbes, and we have aerobes and anaerobes. Okay, so peritonsillar abscess, usually polymicrobial infection, and the organisms which are present can be strep pyogenes, strep, not aeruginosa, but strep anginosus, okay, and then Staphylococcus aureus, and includes methicillin-resistant Staph aureus. And some of the anaerobes are Fusobacteria, Prevotella, and Veillonella. All right, but the whole thing here, I don't want you to memorize the names of all these funny bacteria. The main thing is I want you to remember that it is polymicrobial, and the commonest organism is usually strep pyogenes. Okay, good. So, doctors, let's do a quick review of microbiology of peritonsillar abscesses. Let's do a quick review of microbiology of peritonsillar abscesses. So, peritonsillar abscesses are polymicrobial, and we have both aerobes and anaerobes. Okay, and strep pyogenes, or group A strep, is the most common aerobic pathogen, and anaerobe bacteria like Fusobacteria, Prevotella, Veillonella are frequently present. Now, Staphylococcus, which includes MRSA, may also be isolated. Okay, and empiric antibiotic should cover strep, Staphylococcus, including MRSA and anaerobes. All right, so these are the things you want to pay attention to very well. Okay, all right. Now, let's go to evaluating patients with peritonsillar abscess. Doctors, please, before we move on, I hope the class is now making a lot more sense. I hope it's making a lot more sense. I hope the class is really helping and making a lot more sense now. And we are putting things into perspective. Because at times we can just, read, right? Just read. We are Toronto notes, master the boards, whichever book we want to use. But unless you actually take time to get concepts broken down, you may miss something very important. Okay, so Let's do this. You have a 25-year-old male who presents with fever, unilateral throat pain, and pooling of saliva. He's unable to open his mouth fully. Examination reveals swollen tonsil with fluctuant fullness in the posterior soft palate and deviation of the uvula to the opposite side. Was the most important initial step in evaluation? A. Order a CT scan of the neck. B. Administer IV antibiotics and observe. C. Perform immediate airway assessment. D. Perform needle aspiration to confirm pass. And E. Prescribe oral antibiotics and discharge. What's your correct answer? You have somebody who has fever, unilateral throat pain, pooling of saliva, is unable to open his mouth fully. Examination reveals a swollen tonsil with fluctuant fullness in the posterior soft palate and deviation of the uvula to the opposite side. What's the most important initial step in evaluation? A. Order a CT scan of the neck. B. Administer IV antibiotics and observe. C. Perform immediate airway assessment. D. Perform needle aspiration to confirm pass. And E. Prescribe oral antibiotics and discharge. And the correct answer is C. Perform immediate airway assessment. All right. Don't forget that we are not talking about what investigation will you do. It says what is the most important initial step in evaluation. Whenever you have an emergency case, you want to make sure that you've assessed the patient's airway, breathing, and circulation. That is basic knowledge, right? Before you even do any other thing. Because if you want to even do point of care ultrasound, blah, 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 you need to make sure the patient is able to breathe. Okay, so perform immediate airway assessment. Airway assessment is the first priority when evaluating a patient with suspected peritonsillar abscess. That's the first thing. And what are the signs of airway compromise you need to learn? Please write these down in your wonderful book. Drooling of saliva, tripoding, so the patient takes a particular posture, respiratory distress. Okay, respiratory distress. Now, what about A? Why is CT scan wrong? CT scan is important, is useful, but airway assessment must come first. What about antibiotics? Antibiotics are needed, but not before ensuring that the airway is patent. What about needle aspiration? Needle aspiration will confirm the diagnosis, but should be delayed until airway stability is ensured. And what about oral antibiotics and discharge? It is inappropriate because peritonsillar abscess will require urgent intervention. At times, it may even require that you take the patient to the operating theater. So you can't give oral antibiotics and discharge the patient. That is very deadly. All right? Okay, good. So you have a 22-year-old male who presents with unilateral sore throat, fever, and difficulty swallowing. Examination reveals an erythematous and large tonsils with exudate, but no uvular deviation and trismus. What's the most likely diagnosis? A. Peritonsillar abscess. B. Peritonsillar cellulitis. C. Retropharyngeal abscess. D. Epiglottitis. And E. Ludwig's angina. Sore throat, fever, difficulty swallowing. Erythematous and large tonsil with exudate, but no uvular deviation or trismus was the most likely diagnosis. A. Peritonsillar abscess. B. Peritonsillar cellulitis. C. Retropharyngeal abscess. D. Epiglottitis. And E. Ludwig's angina. It looks like everybody got this right. It's peritonsillar cellulitis. If you remember how we said peritonsillar cellulitis will present with erythema, tonsillar swelling, exudates, but it will lack trismus, right? And uvular deviation. The uvular deviation will come in because of the pus pushing the uvula sideways. Okay. Now, peritonsillar abscess will present with trismus, which is painful or difficulty opening the mouth and painful swallowing. Uvular deviation, and there will be fluctuance. Why would there be fluctuance? Because of the pus, right? Retropharyngeal abscess is more common in children, and usually, as I said, it will cause them to have neck stiffness and difficulty swallowing. And epiglottitis, they will usually come with drooling of saliva and they'll have respiratory distress, but they will not have any tonsillar swelling because it is happening at the level of the epiglottis, not at the level of the tonsils. Right? And Ludwig's angina will cause submandibular swelling, right? Yeah, not peritonsillar findings. Okay. I have another question. Which of the following findings best differentiates peritonsillar abscess from severe pharyngitis or tonsillitis? Which of the following findings best differentiate peritonsillar abscess from severe pharyngitis or tonsillitis? A. Tonsillar exudates. B. Cervical lymphadenopathy. C. Trismus. D. Fever. E. Fatigue. Dr. Oriasoti. Dr. Oriasoti. I think Dr. Oriasoti is either a Manchester United fan or something. He's either a Manchester United fan or something. He's always making fun of another team. I'm not going to mention the name of the team. So, which of the following findings best differentiates peritonsillar abscess from severe pharyngitis? And the answer is trismus. That's C, right? Trismus. So, trismus is the inability to fully open the mouth, and it's a key distinguishing feature of peritonsillar abscess. It results from irritation of the internal pterygoid muscle. Okay, and so tonsillar exudates are common in strep pharyngitis and tonsillitis, but it's not specific to peritonsillar abscess. So the one which is very specific to peritonsillar abscess is trismus. Okay, that is inability to fully open the mouth. So realize that. So Dr. Riasuti says, I love Manchester United and Bendel Insurance. Okay. That's why Manchester United is struggling, you know? Okay, next question. A 26-year-old female presents with severe sore throat, muffled voice, and trismus. Examination shows a swollen tonsil with uvular deviation. The physician suspects bilateral peritonsillar abscess. What's the major concern in this scenario? A. Increased risk of deep neck space infection. B. Development of streptococcal glomerulonephritis. C. Risk of rheumatic fever. D. Airway obstruction. E. Spread to the middle ear through the eustachian tube. So if somebody has bilateral peritonsillar abscess, what's the major concern there? Is it A. Increased risk of deep neck space infection? B. Development of streptococcal glomerulonephritis. C. Risk of rheumatic fever, airway obstruction, or spread to the middle ear through the eustachian tube? And the correct answer is D. Airway obstruction. Okay. So usually you have to understand that bilateral peritonsillar abscess is rare, but if it happens, it can cause significant airway obstruction. We've seen pictures where the patient has unilateral peritonsillar abscess, and we see that it's almost closing the airway. And in fact, one of the doctors was asking, how will this patient breathe? So can you imagine if the patient has it on both sides? That is wild, right? So the main concern with bilateral peritonsillar abscess is the fact that it can cause airway obstruction. Doctors, please, as we are talking as well, I'll suggest kindly go to our YouTube channel, click on the like and the subscribe button, okay, so that we can grow this channel with you. By your help, we hit 2,000 subscribers. So that means that the algorithm will see it and suggest the video to more doctors. So there'll be more people in your country who probably need to also hear this good news of, you know, the fact that MedCognito has all these services to offer. It would be good for you to just click on the like and the subscribe button. Oh, sorry. Dr. Brony, you spiked a question. I don't know what that is. Which question was that, Dr. Benedicta? Can you let me know, please? Okay. So, doctors, before we continue, I just want you to remember that come this week, we're going to have our first mock exam for the period. And this time, we're going to do the mock exams every week, every single week, okay? Every single week. MedCognito will be conducting a mock exam for QE1 candidates. So if you're in MedCognito already, you know, it is what it is. That is my funny face down there, you know, inviting you to just register. And all these doctors are urging you on to just register. If you're a MedCognito candidate, it's going to be for 3 hours, 230 questions. Okay, 230 questions, and focused on all systems. It's only $24.99 for MedCognito candidates. But if you're not a MedCognito candidate and you still want to come and take the mock, you are more than welcome. Okay, it's only $69.99. What I'll do is I'll look for the link and share the link with you. Okay, so that you can come in to take the exam. So for the MedCognito candidates, don't worry, we'll send you the link in your email. But those who are not MedCognito candidates, you can use the link here. You can use it to register. So for those in MedCognito, it's just $24.99. $24.99 just to come and sit for the mock exams. And that is one of the ways we are preparing you to be exam ready on the exam day. So I'm just putting the link in the comment section. You can use that to register. This is going to help you so you can really be able to prepare yourself, you know, manage yourself, take away test anxiety. So we're doing this every week till your exam. Okay. Oh, really? It says I skipped the difference between pharyngitis and peritonsillar abscess. Really? Doc, maybe I'll look for it and then send you the information in the WhatsApp group, in the MedCognito WhatsApp group. Okay. It will be at 6 p.m. EST on March 5th. March 5th, 6 p.m. EST. March 5th, 6 p.m. EST. March 5th, 6 p.m. EST. And then we will start every week. We'll just go every week. No, $24 for that particular mock if you are a MedCognito candidate. And then someone is asking, do we get corrections afterwards? Yes, you're going to get your marks sent to your email and then why you got the right. So like the way I deal with the questions in class here. Yeah. And then it says, can we enroll at any time? Yes, you can enroll at any time. So the exam date is March 5th, 2025 at 6 p.m. EST Ontario time. There will be an invigilator. That's how we've conducted all our mocks. There will be an invigilator. We will take you through the, onboarding so that you feel like you're on an exam, right? And then someone will be watching over you for 3 hours and you'll be doing 230 questions. Okay. So now, doctors, let's go back to the class. So please take advantage of it. If you're on MedCognito, don't worry. We'll send you a unique link so you can use it to register. But if you're not a MedCognito candidate, then you can use the link in the comment section to register. So someone says, how can I become a candidate? Doctor, send me a WhatsApp right now on +1 306 891 5649. +1 306 891 5649. And I'll help you after the class. Okay? I'll help you after the class. So we are going to review evaluation of patients with peritonsillar abscess. So if you are evaluating a patient with peritonsillar abscess, what do you do? If you're evaluating a patient with peritonsillar abscess, what do you do? First, you assess the airway. Always assess the airway first in suspected peritonsillar abscess cases, especially if the patient is drooling or has tripoding, is sitting in a very uncomfortable posture. If there's trismus, a hot potato voice, or uvular deviation, these are the hallmark findings of peritonsillar abscess. So someone is asking again, what's the time for the exam? The time is 6 p.m. Ontario time, 6 p.m. EST, okay? 6 p.m. EST. Now, peritonsillar abscess can cause airway obstruction, especially if it is bilateral, okay? And peritonsillar cellulitis will present with peritonsillar or tonsillar erythema and exudate, but lacks uvular deviation and lacks trismus. Why? Because there's no abscess behind it. And differentiating peritonsillar abscess from other deep neck infections like retropharyngeal abscess, which will present with neck stiffness and fever, and the patient will look very toxic, as well as epiglottitis, where the patient will be like this and will be drooling of saliva, right? Remember the retropharyngeal abscess and epiglottitis, you want to get a lateral soft tissue x-ray of the neck. with peritonsillar abscess, your first initial investigation will be an ultrasound. If you don't have an ultrasound, you can put in a needle to drain and to check whether there's pus. Then if that doesn't help, you can then go for the CT scan. So before anything else, check if the patient is struggling to breathe. And what are the signs of airway obstruction in peritonsillar abscess? Number one, drooling of saliva. Number two, tripoding, where the patient is leaning forward to breathe. And if there's respiratory distress, and if these are present, then what you want to do is that you want to secure the airway immediately before proceeding with evaluation. Okay? If these are present, secure the airway immediately before proceeding with evaluation. So someone says, will this class be posted on YouTube page? No. So that's why I'm putting the comment or the link to register in the comment section. And someone says, what about if I can't do the exam on the set date because of the time differences and zones? Doctor, so what you do is that you send an email to our administrator and he will arrange something for you. Okay? All you need to do is just send me a message on WhatsApp. We'll sort everything out for you. Okay? If you can't take the exam on that same time and date, let us know. Usually, it is good that you put yourself in the exam situation. But if you can't, let us know. We'll be able to help you. Okay? Good. So, what are the signs of respiratory distress again? Drooling of saliva, tripoding, respiratory distress. And if these are present, what you want to do is to secure the airway immediately before proceeding with evaluation. Now, how does a patient be with peritonsillar abscess present? They will have severe sore throat. They will have fever. They will have a hot potato or muffled voice. They will have pooling of saliva or drooling. And they'll have trismus, which is difficulty opening the mouth. Okay? And they may have neck swelling and some neck pain. And they may have ear pain on the same side of the abscess. So if the abscess is on the right, they may have right ear pain. And they may have fatigue, irritability, and difficulty eating. Okay? These patients, this is how they'll present. Now, how do you remember the symptoms of peritonsillar abscess? Write this down. Hot pain. Okay, so they'll have a hot potato voice, as we said. They'll have odynophagia, that is painful swallowing. They'll have trismus, that is pain and difficulty opening the mouth. Okay, they'll have pooling of saliva. They will have asymmetry of the uvula. They may have ipsilateral ear pain. So please write it down. Hot pain. Mnemonic to remember peritonsillar abscess symptoms. Okay, and they may have neck swelling as well. Neck swelling. All right, so history of peritonsillar abscess. If you are taking a history of a patient with peritonsillar abscess, what do you ask for? Remember that in MedCognito, we have a system we use to teach every system, every question, every topic. So, for example, every topic you need to learn what are the historical features, what are the physical exam features, what are the examination features, what are the investigations, right? What's the management plan, and what are the complications? And at times you can add a seventh one. What are the indications for referral? Every topic. So whether you're dealing with headache, you're dealing with abdominal pain, history, physical exam, investigation, management, complication, indications for referral. You want these things. So on the history of peritonsillar abscess, what are the questions you want to ask? Has the patient had any past throat infections before? Have they had frequent or severe pharyngitis? Right? Has there been a previous history of peritonsillar abscess before? Is there a history of snoring, or is there a history of sleep apnea symptoms? Why is it important? If you have a patient who has been having recurrent peritonsillar abscess, part of your long-term management goals will be to request an otorhinolaryngologist to perform tonsillectomy. Okay? So, what do you ask on history? Have you had any past history of throat infections? Have you had any frequent or severe pharyngitis? Is there a previous peritonsillar abscess episode? And is there snoring or deep or sleep apnea? If it comes out in the history that the patient has had recurrent peritonsillar abscess or frequent throat infections, that patient may require tonsillectomy. Doctors, please, are we all on the same page? Let me know. Are we all on the same page? If we're all on the same page, kindly let me know. Just tell me yes, Dr. Bonnie, yes. If we're all on the same page, let me know. Okay, good. Physical exam of a patient with peritonsillar abscess. What are you going to look for? You're looking for swollen fluctuant tonsils. You're looking for an uvula which deviates to the opposite side. So if the peritonsillar abscess is on the right, the uvula will move to the left. If the peritonsillar abscess is on the left, the uvula will move to the right. Okay, you're looking for bulging of the soft palate with palpable fluctuants. And you are looking for trismus, which is really common. Difficulty and pain opening the mouth. Okay, difficulty opening the mouth. Dr. Abba AC, don't worry, go ahead and do the registration. The team will clarify that, okay? Don't worry about it. The team will clarify that. So far as you go ahead with your registration, we'll pick it up and then make the correction. So I'll tell the team to look at it. It's not December 2nd, it is March 5th, okay? Probably it's an old examination or an old mock that they forgot to change. I'll tell them. Okay. So what are the physical examination findings for peritonsillar abscess? What are you going to look for? Bilateral peritonsillar abscess, remember, it is rare, but it's very dangerous. And the point we are concerned about is that it can cause airway obstruction, right? In bilateral peritonsillar abscess, instead of the uvula being moved to the left or to the right, depending on where the abscess is, usually the uvula will be displaced anteriorly. Because there's abscess here, so it's trying to move here, and then there's abscess here, so it's stuck between the two. There's like, okay, where do I move? It will move anteriorly, right? So in bilateral peritonsillar abscess, the uvula deviates forward or anteriorly. On right peritonsillar abscess, the uvula will deviate to the left. On left peritonsillar abscess, the uvula will deviate to the right. And the main concern we have with bilateral peritonsillar abscess is airway obstruction. I think a lot of people have a lot of questions. So someone is asking, is this conducted at a specific center? No, doctor. We are going to conduct it like a remote proctored exam, because remember that the MCQE1 exam, you can write it at any good prometric center, or you can even write it at home, and the prometric centers will get an invigilator for you. So that is what we are going to replicate. Okay, we've done it several times, and that is what has given a lot of our candidates a lot of success, because they are just doing mock exams back to back to back to back to back, and then they get their feedback and give them feedback, and they come again the next week and they do it. So you don't need to travel anywhere. You be in the comfort of your home behind your laptop. The examiner will be watching you and just be doing it like a main exam. Okay. Now, physical examination for peritonsillar abscess and what to look for. So for peritonsillar cellulitis, remember that there's no pus. So that one, there's no uvular deviation and there is no trismus. Usually there's reddening of the tonsils, there's swelling of the tonsils, and there's exudates. That's all. There's no uvular deviation and there's no trismus. Okay. Now, what's the key differentiator between peritonsillar cellulitis and peritonsillar abscess in terms of physical exam and the way the patient will present? With peritonsillar abscess, the patient will have trismus and uvular deviation. In peritonsillar cellulitis or strep pharyngitis, that's Dr. Glover, I think I'm answering your question now. There is no trismus, there is no deviation of the tonsils and the uvula. Why? Because there's no abscess behind it, right? There's just erythema and some exudate formation. And when are you going to consider imaging in throat infections? If you are unsure what it is, so for example, peritonsillar abscess versus epiglottitis, the patient is drooling, the patient looks toxic, there's high fever. Or if you are doing like peritonsillar abscess versus retropharyngeal abscess, where the patient is presenting with neck stiffness, bulging posterior pharynx, right? So with epiglottitis and retropharyngeal abscess, you want to do a lateral neck x-ray. So when are you going to do a CT scan? Remember when we started the class, I said that people were mentioning CT scan, CT scan, CT scan. And I was saying, we will get there. Okay. So you will request a CT scan if the exam is unclear. For example, you look in the throat, you can't see any uvular deviation, but the patient looks so sick. And you are suspecting that there's a deep neck space infection. And you can see some bilateral swelling with airway concern. Then you may want to consider a CT scan. However, please make sure that the patient's airway is patent before you put the patient in that tunnel. That is called a CT scan machine. All right. So someone is asking here, how do you differentiate between exudate and abscess? Abscess causes fluctuance. Exudates are those white patches you see on the tonsils when you look into the mouth itself. The exudate, you realize that they are just white patches. Meanwhile, the abscess, it causes this area of a bulge, and if you touch it, it's fluctuating, right? Okay. So when you go to the operating room, if there is severe trismus, which is preventing oral examination. So I remember when there was one question and someone said, oh, but can the patient open the mouth? If the patient cannot open the mouth at all, then we are in trouble. We need to go to the OR. That's the operating room. Okay, if there's severe drooling and difficulty breathing, then you are thinking about, look, we need to act fast. We need to start the patient on some oxygen, find a way to maintain the airway, and move the patient to the theater. Maybe we may have to create, a different path for the patient to breathe. Okay, so what are the investigations for peritonsillar abscess? We've talked about ultrasound. We've talked about when to do needle aspiration. We've talked about culturing the pus. We've talked about all those things. But now let's dive deep. Is it everybody with peritonsillar abscess that we need to do a CBC for? What's the indication for CBC? Why do we do CBC? Do we need CBC at all? These are the things we're going to look into. Okay. So before we move in here, Dr. Maria Usman says 230 questions in 3 hours. I'm confused a bit. I think the actual exam format is 230 questions in 6 hours. Is so, yes. So we want to make sure that we train you to be able to pick up your answers quickly. So yes, you are going into battle. So we're going to make the training a bit tougher as compared to the actual battle. So when you go into the battle, it's easier for you. That is the rationale behind it. Yes, doctor. That is the rationale behind it. Right? Good. Because remember that at first, people would do 210 questions in 3 hours, right? So we are just extending it a little bit. We can make it 3.5 hours just so that candidates can have some easier time. But we just want to make sure that candidates are getting it and are well prepared for the exam. Okay, so let's go to the next question. So you have a 14-year-old boy who presents with sore throat, fever, and difficulty swallowing, and muffled voice. On examination, he has trismus, unilateral tonsillar swelling with uvular deviation, and tender cervical lymphadenopathy. His vital signs are stable and he's tolerating oral fluid poorly. A rapid antigen test for group A strep is negative. Which of the following is the best next step in the evaluation of this patient? A, perform CT scan of the neck with contrast. B, obtain ultrasonography by an experienced clinician. C, perform immediate needle aspiration for culture and drainage. D, order a complete blood count and serum electrolytes. And E, administer broad spectrum antibiotics, IV, and observe the patient. While you are answering this question, I think some of the questions have also come through. What was the last date for this session? Doctor, which session? MedCognito does not have any last dates and a first date. We keep teaching around the clock, okay? And then someone is asking, Dr. Nabila says, Dr. Boni, is there a French version of that exam, please? I think the French, those who have come in for the French, there's something the administrator can do. And I think it's able to turn the questions into French. I don't know. I'm not technically savvy, so I don't know. But you can send me a WhatsApp message and I can talk to the administrator and we'll see if we can get you a French version, okay? Someone says, can't see the rest of the option. The pop-up is blocking it. Oh, okay, sorry. The pop-up. Okay. Sorry. Okay. Sorry. Have I taken the pop-up off now? Can you see it now? Can you see it now? Okay, good. Sorry, I didn't know that. I forgot that the pop-up also comes and covers the page. So, a 14-year-old boy presents with sore throat, fever, difficulty swallowing, and muffled voice. On examination, he has trismus, unilateral tonsillar swelling with uvular deviation, and tender cervical lymphadenopathy. His vital signs are stable and he's tolerating oral fluids poorly. A rapid antigen test for group A strep is negative, which of the following is the best next step in evaluation of the patient? A, perform CT scan of the neck with contrast. B, obtain ultrasound by an experienced clinician. C, perform immediate needle aspiration for culture and drainage. D, order a complete blood count and serum electrolytes. And E, administer broad spectrum antibiotic. And the correct answer is B. We've learned this already. We know this. We've mastered this, that this patient has classic symptoms of peritonsillar abscess. While peritonsillar abscess is a clinical diagnosis, we need to do the ultrasound, right, to confirm an abscess before we perform drainage. Ultrasound is more sensitive and specific than clinical examination alone, and it helps to distinguish peritonsillar abscess from peritonsillar cellulitis, right? We learned that we'll do a CT scan only when we are thinking about retropharyngeal abscess and parapharyngeal abscess and epiglottitis and the rest, right? And we learned that immediate needle aspiration can only be done after we've done our ultrasound, or if we don't have an ultrasound, then you don't want to do a needle aspiration to confirm if there is pus. But if you have ultrasound and you have needle aspiration, use the non-invasive method first. All right. And then CBC and electrolytes, they may provide supportive data, but are not essential for diagnosis. And we also learned that if the patient has retropharyngeal abscess and you just give antibiotics, if so far you've not drained the abscess, we are in trouble, right? So far as you've not drained the abscess, we are in trouble. All right? Okay, good. Next question. 17-year-old girl presents with a sore throat, difficulty swallowing, fever, and a hot potato voice. Examination reveals unilateral peritonsillar swelling and contralateral uvular deviation. The emergency physician performs an intraoral ultrasound, confirming a fluid collection consistent with a peritonsillar abscess. Which of the following microbiologic evaluations is most appropriate? A, blood cultures to assess for bacteremia. B, rapid antigen detection test for group A strep. C, Gram stain and culture of the abscess fluid. D, Epstein-Barr virus serology. And E, throat swab for bacterial culture. Doctors, can you imagine? We've done 1 hour, 30 minutes already. Do you feel tired? We've done 1 hour, 30 minutes of this important topic. We've done 1 hour, 30 minutes. Wow, this is good. It's a very good way to spend your afternoon, right? Instead of watching Netflix and all those things, you spend it watching Dr. Brony doing MCQ on Netflix. Okay, so which of the following is a microbiologic evaluation is most important? You want to do gram stain and culture of the abscess fluid, right? Now, you do blood cultures only when you think that this patient looks really, really sick, right? But then you remember that there are various organisms, and we learned that the organisms which cause retropharyngeal abscess, they are polymicrobial, right? So the best microbiologic test for this abscess is gram stain culture and susceptibility testing of the abscess fluid, and it is obtained during drainage. Okay, this helps guide antibiotic therapy. So why do you need to do your gram stain? Because it helps to guide antibiotic therapy, especially in immunocompromised patients or patients with complications. And blood cultures are not routinely indicated for uncomplicated retropharyngeal abscesses. Okay. Yeah. So we have a 12-year-old boy with suspected peritonsillar abscess. He's unable to fully open his mouth due to pain and trismus, making intraoral ultrasound difficult. His vital signs are stable, and there are no signs of airway compromise. Which of the following is the most appropriate next diagnostic step? A. Perform submandibular ultrasound. B. Order contrast-enhanced CT of the neck. C. Perform a bedside drainage procedure without imaging. D. Obtain a throat culture for group A strep. And E. Start IV steroids and antibiotics without further testing. Intraoral ultrasound is difficult. His vital signs are stable, and there are no signs of airway compromise. Which of the following is the most appropriate next diagnostic step? Doctors, thank you for hanging on with me. I know at times, these classes can be long, but doctors, I'm sorry, I can't help it. I need to be here with you. We need to study together. I'm not leaving you. You need to pass this exam, right? You need to pass the exam. That is why we are spending the time doing this. So don't get tired. Rather tell your friend or your wife or your daughter to get you some orange juice or some apple juice, and let's continue. I will not leave you. I will not give you time to get up and walk around. We are going to study together. So what's the correct answer? The correct answer is perform a submandibular ultrasound. Okay, so you want to do everything possible to get an ultrasound. So if intraoral ultrasound is not feasible, okay, due to trismus, pain, or gagging, then submandibular ultrasound is a preferred alternative. You go for the needle aspiration if ultrasound is not available at all. Okay, so it avoids the limitations of intraoral ultrasound and is superior to clinical examination alone, right? So the issue of bedside ultrasound or the bedside drainage, it should not be performed without confirming an abscess. Because why would you stick in a needle to try to drain? Remember that there are two things here when you're sticking a needle. Number one is to confirm your diagnosis, and number two is actually to drain the abscess. Okay? So when do you stick in a needle to confirm your diagnosis? That is when there is no ultrasound available. So there are two types of ultrasounds. We have the intraoral, where you actually put the ultrasound probe in the mouth, and we also have the submandibular ultrasound. Now, this patient could not open the mouth for the intraoral, but at least you can do a submandibular ultrasound. Okay? Dr. Sabine is asking me to show the question again. You can do the submandibular ultrasound. Don't also forget that the question says that his vital signs are stable and the patient has no signs of airway compromise. So it's not like you are really racing against time. What should I do? No. The patient is stable. The patient is able to breathe. But you just can't get the probe into the mouth to do an intraoral ultrasound. But instead of the ultrasound probe, what can you do? You can do a submandibular ultrasound. You do the needle tap only when there's no ultrasound available. Okay, good. So let's do a deep dive into investigations for evaluation of patients with peritonsillar abscess. So number one, never be tricked in your board exams. Do we need lab tests to diagnose peritonsillar abscess? The answer is no. So if you see a patient with suspected peritonsillar abscess and you see CBC, renal function test, liver function test, no, run away. Bam, bam, bam. Run away. Why? Laboratory tests are not required to diagnose peritonsillar abscess. Peritonsillar abscess is a diagnosis which is primarily clinical. If you're able to get your ultrasound or if you're able to look at the clinical presentation, You check there's a swelling, uvula is deviated. Even if you don't have an ultrasound and the patient can open the mouth and you can stick your needle in and get some pus, you've confirmed it. You don't need CBC to tell you that this patient has retropharyngeal abscess. It's a diagnosis which is primarily clinical. However, lab tests can help you to assess the severity for dehydration, and it can also help you to guide your treatment. That is why you do labs. You don't do labs to help you to diagnose peritonsillar abscess. You rather do labs to help you to assess severity, dehydration, and guide treatment in certain cases. So, I drew this table for you. What are the labs? Remember, none of these labs is going to help you to make your diagnosis, okay? If you can see my cursor on your screen, none of these labs is going to help you, but they are going to help you to tell the severity and to also guide your management. So CBC with differential, you do it to check for systemic infection. And usually you will realize that there's elevated white cell count, mostly polymorphonuclear neutrophils, okay? And it suggests that there's a bacteria involved. Then you can do your serum electrolytes. Remember that this patient has painful swallowing, difficulty swallowing, and the MCC objective you are dealing with is approach to dysphagia. So you want to do your serum electrolytes. Why? Because it helps you to assess for the level of dehydration if the patient is having poor oral intake. And so in that, you are looking for possible signs of dehydration. And then you do your rapid strep test to check for group A strep, because don't forget that they are the most common organisms which can cause retropharyngeal abscess, right? And it is preferred over culture for fast results. And then you can do your throat culture if rapid test is negative, but strep is still suspected because it can confirm. So why will you do your rapid strep test? It is to get the results quickly, but if you want to actually confirm, then do your throat culture. And what about gram stain and culture of abscess fluid for immunocompromised patients or patients with complicated infections? It helps to identify the aerobic and the anaerobic bacteria, and it guides the antibiotic selection. Okay? So, if the patient is clinically stable, this is the key point. Remember, if the patient is clinically stable, lab tests don't change management. Abscess fluid culture is most useful in high risk or complicated patients. And high risk patients are, for example, a patient with HIV, for example, a patient who is immunosuppressed from maybe chronic use of steroids, or a patient who is on immunosuppressants for whatever reason, maybe chemotherapy or something. Then that is when you want to get your fluid culture. Why? Because it can guide you, so it can really, really nick in the particular organism and its sensitivity, so you can get the right antibiotic to manage that particular patient. All right. So back to this. When to use imaging in the diagnosis of peritonsillar abscess? Imaging is not always needed for peritonsillar abscess diagnosis. We realize that the first imaging you want to do is your ultrasound, intraoral. If you can't do it, you can do your submandibular. If you can't do that, then, or if they don't have it, then you want to stick in your needle. If that is not there, then you may then want to consider your CT scan, right? So use imaging if unclear diagnosis. Is it peritonsillar abscess? Is it peritonsillar cellulitis? Is it retropharyngeal abscess? Is it parapharyngeal abscess? Okay. Use imaging if there is concern for deep neck infection, like retropharyngeal abscess, parapharyngeal abscess, epiglottitis. Use imaging when there is severe trismus, which prevents oral examination. Doctors, please, I hope this is becoming clear. So what are the imaging options for peritonsillar abscess evaluation? Remember, ultrasound is the first line. It is a preferred imaging test if available. It confirms pus collection before you drain it, and it helps you to differentiate between peritonsillar abscess and peritonsillar cellulitis, right? Peritonsillar abscess, you will see echo-free cavity with irregular borders. Don't worry about all the detailed ultrasound findings that Dr. Bruni is just putting down there. That is all highfalutin stuff. But remember, first line imaging you want to do if a patient has peritonsillar abscess, or you think about peritonsillar cellitis or something, is your ultrasound. First is intraoral ultrasound. If you can't get that, then you want to get a submandibular ultrasound. Okay. Now, when to do a CT scan? No, not needed to confirm peritonsillar abscess alone, because it exposes the patient to radiation. But usually it is used when you want to differentiate peritonsillar abscess from deep neck infections like like para. I'm even tired. Like these deep neck infections we're talking about. So before the class continues, I'm not still done. There's still some management stuff we need to learn. I want to also remind you that those who are in MedCognito now, apart from the mock exams which you'll be doing every week, you also have your med drills which will be coming on. The first one will be on March 10th. The next one will be on March 26th. Every month, the candidates choose a topic that they want me to come and deal with. Not just one topic, but the whole system. Okay. So in January, it was for ethics, where we did a top-up class, 6 hours, and it was bam, 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 bam. Then in February, it was psychiatry. And then in March, they said, Dr. Bruni, emergency medicine covers about 30 to 40% of the MCQ1. So if you look at the way the MCQ1 questions are distributed on the MCC website, you realize that emergency medicine or acute medicine covers about 30% to 40%. So that means out of every 10 questions, you're going to meet 3 to 4, which is emergency medicine and acute medicine. All right? So on March 10th and on March 26th, we're killing emergency medicine. Okay? The first class alone has more than 350 slides that we're going to encounter. It's question, answer, boom, 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 boom. Okay? So come and get drilled and let's get prepared. So you can still send me a WhatsApp message on +1 306 891 5649 and we'll get going. Okay? So you may say, hey, Dr. Bruni, I just want access for 1 month. Sure. You get $450. That is it. Someone may also say, Dr. Bruni, I want access for 6 months. It's just $420 every month for 6 months. Someone may say, Dr. Bruni, I just want 3 months access. It's just $1,350 for 3 months access. Some also say, Dr. Bruni, I want 6 months access, but I want to pay one time. That is just $2,199. Doctors, just reach out. You get access to all the teachers. You get access to a supporting community. You get access to me. You get access to med drills. You get access to med bullets, which is like almost 2,700 topics reviewed for you in fast-paced way. You get access to live classes. And don't forget, tonight you have a class. So those in the MedCognito group, don't forget, tonight you have a class. I think it's on gastroenterology or so. Tonight you have a class, right? And then on the 5th of March, you have an exam. And on Thursday, you have another class. Then on the 10th, you have med drills with me. And then it goes on and on and on and on and on. Okay? So doctors, okay, so I'm told that tonight you have gastroenterology. Beautiful. So yeah, that is good. So after this class, get some rest and then jump into the gastroenterology class right away. Okay, so let's review management of peritonsillar abscess. And what I want you to do is that I want you to master the steps. In fact, for peritonsillar abscess management, there's a whole lecture I need to do for you. Okay, but today I'm going to give it in broad strokes because of the fact that some of you are tired. Okay, so 16-year-old boy presents to the emergency department with fever, severe sore throat, difficulty swallowing, and a hot potato voice. On examination, he has trismus unilateral peritonsillar swelling with uvular deviation and a palpable fluctuation of the soft palate. His vital signs are stable and is not in respiratory distress. What's the most appropriate next step in the management of this patient? A, administer empirical IV antibiotics and reevaluate in 24 to 36 hours. B, perform a contrast-enhanced CT of the neck. C, perform an ultrasound-guided needle aspiration. D, refer to the otorhinolaryngologist for incision and drainage under general anesthesia. And E, obtain a throat swab for group A strep testing. So a lot of doctors are going for C, and the answer is C. Perform an ultrasound guided needle aspiration. Okay, so this patient has classic features of peritonsillar abscess, which includes fever, trismus, uvular deviation, and soft palate fluctuation. And the next step is ultrasound guided needle aspiration. Okay, as this confirms an abscess and allows for immediate drainage. Now, one answer people were confusing with C was D. Incision and drainage under general anesthesia is reserved for patients who are unable to tolerate bedside drainage. So in reality, peritonsillar abscess, if you have good ultrasound skills and you can do you can spray the throat just so that the patient is comfortable, you should be able to do it in the emergency room. All right? You only do incision and drainage under general anesthesia if the patient is unable to tolerate bedside drainage. What about empiric IV antibiotics alone is not enough? There's an abscess. It must be drained. What about contrast enhanced CT? Is not needed unless there's suspicion of deep neck space infection. What about a throat swab for group A strep? It does not diagnose peritonsillar abscess and is unnecessary once an abscess is confirmed. Remember that we said that all the labs, we do them not to confirm the diagnosis, but to help us to manage the patient and to help us to know the severity of the symptoms. That is it. Okay? Good. Next question. Next question. A 22-year-old woman presents with sore throat, fever, difficulty swallowing, and mild dehydration due to decreased oral intake. Examination reveals mild unilateral peritonsillar swelling without palpable fluctuation, no uvular deviation, and no significant trismus. Ultrasound does not reveal discrete fluid collection. What's the best next step in management? 22, let me read it again. 22-year-old woman presents with sore throat, fever, difficulty swallowing, and mild dehydration due to decreased oral intake. Examination reveals mild unilateral peritonsillar swelling without palpable fluctuation, no uvular deviation, and no significant trismus. Ultrasound does not reveal a discrete fluid collection. What's the best next step in management? A. Perform needle aspiration to confirm absence of pus. B. Start empiric IV antibiotics and reevaluate in 24 to 36 hours. C. Order contrast enhanced CT to assess for deep neck infection. D. Refer for surgical incision and drainage. And E. Perform a throat swab for bacterial culture. What's the correct answer? What's the correct answer? I see A, B, E. It's all over the place. And the answer is B. It's very simple. Why is it B? This patient, look at the question very well. Sore throat, fever, difficulty swallowing, mild dehydration, mild unilateral peritonsillar swelling without palpable fluctuation. So in other words, this patient does not have an abscess. There is no uvular deviation. There is no significant trismus. Remember that we said that what separates peritonsillar abscess from peritonsillar cellulitis is the presence of trismus, right? Ultrasound does not also reveal any discrete fluid collection. In other words, remember that we said the indication for doing an ultrasound is to separate peritonsillar cellulitis from peritonsillar abscess. And so this question is basically telling you, Dr. Aruj, Dr. Misbao, Dr. Dogua, Dr. Sekina, all of you on this broadcast right now, this patient does not have peritonsillar abscess. And if the patient does not have peritonsillar abscess, what other diagnosis looks like peritonsillar abscess but it's not peritonsillar abscess? And the answer is peritonsillar cellulitis. And if there's peritonsillar cellulitis, what do? The answer is B. You start empiric IV antibiotics and you reevaluate the patient in 24 to 36 hours. However, if the patient has peritonsillar abscess, don't start empiric antibiotics and reevaluate in 24 to 36 hours. Rather, you want to drain before you do your antibiotics. So this patient likely has peritonsillar cellulitis, not abscess, because there's no fluctuancy on the exam, no fluid collection on ultrasound, and the best step is to do empiric IV antibiotics and reevaluate in 24 to 36 hours. And everybody said, amen, right? So Needle aspiration is unnecessary because there's no fluid collection. So A is wrong. Contrast enhanced CT is not necessary because contrast enhanced CT is for deep neck infections. And incision and drainage is only for confirmed abscesses. We could not confirm an abscess here. There is no fluid. You did the ultrasound, there was no fluid. And a throat swab does not help peritonsillar infection because peritonsillar abscess is often polymicrobial. Next question. A 19-year-old male with peritonsillar abscess requires drainage. Okay, the emergency physician attempts bedside needle aspiration, but the patient experiences severe gagging and pain, making the procedure impossible. What's the most appropriate next step? A. Attempt intraoral ultrasound and repeat aspiration. B. Administer IV steroids and antibiotics without drainage. C. Perform incision and drainage in the operating room. D. Perform a contrast enhanced CT of the neck. And E. Start broad spectrum antibiotics and reevaluate in 24 hours. So it looks like this one, we've confirmed the peritonsillar abscess. We're trying to do it in the ER. It didn't work. So what do? We need to take the patient to the OR, right? Remember, we said the peritonsillar abscess, you can drain it in the ER, emergency room. But we tried. It didn't work. So what do? We take the patient to the OR and drain. Simple. Simplicity. We don't waste time about this at all. It is C. Okay? So today, I just want us to master the steps in management of broad spectrum antibiotics and in management of peritonsillar abscess in broad terms. Okay, so step 1, clinical diagnosis based on symptoms and exam. So you look at the mouth, trismus, patient has deviated uvula, swelling, fluctuancy. Okay, so look for trismus, look for uvulated uvular deviation, look for fluctuance. Then you confirm with ultrasound, which determines if there's abscess presence, and then the ultrasound will also tell you the size of the abscess. And the ultrasound will also help you to differentiate between peritonsillar abscess and peritonsillar cellulitis. And number 3, is the abscess very small or there's no abscess? If it is very, very small, very, very small, tiny little thing, then no drainage is needed. If it's very tiny, you can't even tell where it is, then you can give you antibiotics and IV fluid. But if it's a large abscess like what we've been describing, can patient tolerate drainage in the ER? If the patient can tolerate the drainage, do the drainage in the ER. But make sure you've anesthetized the mouth and the throat. If the patient cannot tolerate the drainage, do your incision and drainage in the OR. And don't forget to then cover your patient with some antibiotics as well. Okay? So, as I said, when it comes to this, we still need to do another class on deep differentials, the management, complications. And doctors, we've done almost 2 hours of class already. And so I was thinking that maybe this is too much knowledge, to just keep going on and on and on and on. So I have a question. Please, has the class made sense so far? Before we end the class, before we get into the final stages of the class, so far, has it made a lot of sense? So far, has it made a lot of sense? For me, it's made a lot of sense to me. I don't know for you. Has it made a lot of sense? And so you realize that we need to schedule another time to do actual deep differentials. How will I separate peritonsillar abscess from epiglottitis, from this, from that, we talked about some of them, but there's a whole class I need to do again to go deep, and then specific management. So yes, we talked about the first step and clinical diagnosis confirmed with ultrasound. Is it a small or large abscess? If large abscess, can the patient tolerate? But then there's even more deeper stuff that we need to do. Oh, doctors, it's been awesome. And I think what we can do is that we can cover a lot in the med drills, because this month we have med drills and peritonsillar abscess is an emergency, right? So we'll cover that in the med drills as well. So, doctors, thank you very much. Please don't forget to prepare for tonight's class. It was a great class you guys gave me. Remember to reach out at +1 306 891 5649. It's always a pleasure. This is my phone number, +1 306 891 5649. +1 306 891 5649. Thank you for spending your afternoon with me. All I want to see is Dr. Brony, I passed. Dr. Brony, I joined the MedCognito program, I passed. But that's all I want to see. So that you are happy, I'm also happy, we are all overjoyed, right? Doctors, that's all I want to see. And that is what is my motivation for this. So please, I've seen some text messages have started coming through. If you want me to contact you right away after this class, send me a WhatsApp message right now. +1 306 891 5649. Remember, you can join us for just 1 month for just $450. For 3 months, for $1,350. For 6 months, for $420 a month, or $2,199. Right? Thank you so much, doctors. It's been a pleasure spending my afternoon with you, as we always do. Please, the weather is warming up, so get out there, get a walk. The fact that you are learning doesn't mean you shouldn't do your treadmill. So every morning, do at least 30 minutes. Drink a lot of water, at least your 8 glasses of water, and don't let the exam overshadow you. Okay, we are here to help. Reach out, and Dr. Brony and the team will help you greatly. Okay, this is our phone number, +1 306 891 5649. Reach out right now. I'll be picking up the calls as soon as the class is done. Thank you, doctors. Have a wonderful day and enjoy. Bye-bye. And for those in MedCognito, don't forget, you have a class tonight. Thank you. I'm out of here. Bye-bye, 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 bye-bye.